como siempre decimos, aportando y tratando de comunicarles a los expertos sus consultas, sus dudas. Como les dijimos al principio, va a ser una charla en inglés, pero la pueden hacer en castellano, nosotros las vamos traduciendo, así los speakers van entendiendo. Déjame que les recuerde que si la gente no se puede conectar al Zoom, estamos saliendo en YouTube en vivo, para que en alguna de las dos plataformas puedan participar y no se queden sin ver la charla. Estamos a 10 minutos. Bueno, Hansel, un placer tenerte. Sos de República Dominicana, ahora estás en Cleveland haciendo tu máster, tu fellow en oncología, también realmente algo impresionante.
Sí, bueno, realmente yo nací en Guatemala y me mudé a República Dominicana cuando tenía 16 años aproximadamente. Entonces ahí
Bien.
pude hacer la carrera de medicina, la residencia de oftalmología, pero sucedió algo muy interesante y antes de entrar a la residencia fue que tuve la oportunidad de trabajar en un hospital dedicado solamente a oncología ahí en República Dominicana. Entonces tuve contacto con los pacientes oncológicos y con lo que hasta ese momento yo entendía que era el abordaje del paciente oncológico de la forma moderna, que ya lo toma multidisciplinario y que demanda mucho del médico. Porque hablando de oncología de forma general, si un paciente tiene un cáncer de pulmón y se presenta la emergencia con dolor de pecho, lo que uno tiende a hacer es relacionar ese dolor de pecho a lo que es el cáncer de pulmón y decir, bueno, eso es directamente relacionado. Pero a uno se le olvida que el paciente oncológico puede tener también muchísimas otras condiciones que un paciente no oncológico también puede presentar. Entonces, todo eso sirve de base y en base a lo normal que le puede pasar a un paciente, pues uno escala un poco más e incluye las condiciones oncológicas que pueda tener ese paciente. Entonces me llamó mucho la atención, ¿no? También tuve contacto con algunos casos de oncología ocular y que no había nadie que se pudiese hacer cargo de las situaciones. Incluso a los oncólogos clínicos le llegaban pacientes de que no, que tiene un tumor en el ojo y tiene ya invasión esclera. Y ellos decían como que yo no sé qué voy a hacer aquí porque nunca he visto nada parecido. Y en los libros de texto nuestros no aparece nada respecto a eso. Entonces me quedó como esa duda. Ya cuando logré entrar a la residencia, pues me siguió esa duda creciendo y creciendo hasta que, por curioso, me metí a internet a investigar si realmente la especialidad de oncología oftálmica existía en el mundo, en algún lugar o alguien que se dedicara a eso. Me topé también con el libro de texto de los doctores Shields y con el doctor Arun Singh también. Ellos dos como que sobresalían mucho en mis motores de búsqueda. Entonces ya cuando estaba en el tercer año de residencia, pues solicité un observership en ambos sitios, tanto en el Wills como en Cleveland Clinic. Entonces, de donde sí recibí respuesta, la primera respuesta positiva fue de Cleveland Clinic. Entonces, inicié todo el proceso para hacer el observership ahí. Ya cuando estaba adentrado en el proceso, recibí la aceptación del Wills Eye. Entonces, tuve que decidir, bueno, ya yo inicié el proceso con Cleveland Clinic, estoy más de la mitad, ya casi todo aceptado, entonces continué de esa manera. Me encantó realmente las expectativas que yo tenía con la especialidad eran unas y cuando yo conocí de qué se trataba todo esto es mucho mejor de lo que había pensado. Me llama mucho la atención, me gusta muchísimo y por ahí entonces decidí que eso quería hacer como especialidad. Entonces ya como último residente de cuarto año, ya uno va buscando por dónde coger y por dónde, qué camino tomar, ¿no? Al final de cuentas, volví siempre a los dos mismos lugares, Hillside y Cleveland Clinic. Sometí mi solicitud al mismo tiempo de ambos sitios. Me aceptaron en ambos lugares, algo que me sorprendió bastante. Pero había algo diferente, ¿no? Parte de los requisitos yo los tenía y precisamente por un requisito en particular fue que no pude continuar el proceso en el Hillside. Ese requisito era respecto a una beca. Entonces, la beca me la dieron, pero en Cleveland Clinic. Entonces, por eso es
Hansel,
que
¿y
terminé en Cleveland Clinic.
cuándo terminas? Ahora en junio me comentaste, ¿no?
Sí, a finales de junio es que yo termino
Junio y ya
el fellowship.
listo para volver a Dominicana, un país que tenemos muchos amigos y la verdad que qué bueno que o que puedan contar con un especialista del nivel de ustedes, tanto en República Dominicana como en el caso de Monterrey, que estás en el TEC, David, ¿no?
Así es, aquí estoy en el Tecnológico de Monterrey, es de las universidades privadas con más prestigio del país. Y algo interesante es que está alejado de la capital, ¿no? Eso es algo, es brindarle un servicio que hay muy buenos especialistas ya en la Ciudad de México. Está Daniel Moreno, está el doctor Emiliano Fulda, gente muy respetada en oncología aquí en México, pero que están en la Ciudad de México, y yo creo que yo estando aquí en otro lugar, otra ciudad grande también, la segunda o tercera ciudad más grande del país, también le brinda la oportunidad a más personas de tratarse. Entonces, sí, Monterrey es una ciudad bonita para el que no la conozca. Ahí se come mucha carne y bueno, hace mucho calor. Entonces, el que quiera venir a visitar, mejor venga en algo que no sea verano. Sí.
Bueno, estamos a 4 minutos de empezar, somos medio ingleses en esto, empezamos en punto, todavía estamos esperando a los doctores. Se toma mucha cerveza, dice nuestra queridísima Denise Loya García, sí, sabemos que por eso queremos ir, ¿no? Queremos ir
es adaptación, así contrarrestamos la sudoración.
Bueno, ya somos más de 250 participantes acá, estamos todos muy expectantes de lo que se viene. El doctor Agustín Mozo nos manda saludos, un beso grande a Agustín desde Barranquilla, siempre él y su señora ahí acompañando. Quiero volver a mostrarles lo que se viene mañana, el Thursday, el Tech Thursday, que va a ser impresionante, ¿sí? Que ya se pueden ir inscribiendo, sobre todo al del turno de la mañana, porque es con cupos limitados. Vamos a tener un taller, el formato de taller, como fue el de hoy también en la mañana, aplicado a la innovación, la tecnología. Está muy, muy interesante. Creo que sobre todo los más jóvenes no podemos ser ajenos a esto. Y por la tarde tenemos ya lo que es telemedicina, ¿sí? Ahora y para todos. Bueno, David, a ver, estamos ya con la doctora Dolvin. Hi, Lauren.
Hi.
How are you? Here, okay.
Good, how are you?
Good. We are very happy to have you here. Thank you so much. We were talking in Spanish, waiting for all of you guys. So now we can switch the language and we'll be ready for be talking in English. And also is here Lauren Hanselon. We are all set. Okay. Lauren, you are in Mayo Clinic, right?
Correct, yes.
Okay. Do you want to tell us something about your career, something about your life there in Mayo Clinic before we started?
Oh, sure. So I recently took over in July as the director of the Ocular Oncology service here. So I have taken over the practice of my mentor, Jose Pulido, which has been a really great honor for me. And I am really enjoying my time here. In the Midwest, it's still winter, unlike Mexico. We still have snow on the ground today, but the people are very warm. And when we're not having to practice social distancing, my patients are, I think, some of the most amazing and most grateful people. So I'm really thankful that I get to be here.
Oh, that's so nice. Dr. Williams Jr., hi, Basil, how are you? Welcome.
I'm doing very well. How are you?
Good. We are very happy to have you. This is a very special day for us, for Ophthalmo University, and for all Latin America. It's a honor to have you, to have this team, dream team about oncology, ocular oncology. So we are just waiting for the rest of the speakers, and we will start very soon. David, you want to add something? You want to say something?
Yeah, Lauren, both Dr. Darwin and Dr. Williams, Lauren ambassadors, I like to tell them, are really good friends of mine. Not only great at what they do, ocular oncologists, they are phenomenal, but also they're really great friends and really nice people. So they're very approachable. And the idea of this conference was to be among friends, and I think it will be good in that part. So this is also a great a great excuse to be hanging around good Lauren and Basil. And obviously people might know that unfortunately due to time constraints, we couldn't invite Dr. Williams' partner, Dr. Maura Di Nicola. She is an absolutely phenomenal ocular oncologist and I respect her so much. She's from Italy. And hopefully in other conferences, we'll be able to get to know even more colleagues. So thanks to both of you for accepting the invitation. We're more than thrilled to have you here. And thanks for sharing that info with us.
And I think, David, Dr. Shields is already here. I don't know. Dr. Carol Shields, are you there? Not yet. Let me see.
I see her microphone on, but I don't see her webcam on, her camera. If you need any help.
Okay, I'm here. Can you hear me?
Oh, I hear you.
Yeah, so I'm here.
Okay.
Share screen.
Let me see. You need to put on your camera, doctor. I think so.
Here it says start video. FaceTime high def camera.
Yeah.
Yeah,
Yes.
you probably have to click the start video button.
Exactly.
Okay, mine has a cross through it.
There you are. Now we can see you.
Oh,
Okay.
perfect. We can see you, Dr. Shields.
Oh, how'd that happen?
You must have clicked the button.
I don't know. But
I don't have a great background here, so.
Well, Dr. Shields, it's very nice to meet you. Thank you so much for being here for all Latin America. We are already almost 500 people waiting for all of you guys.
Wow.
So it's a honor, a pleasure to be with you. Thank you so much for your time. It's an enormous pleasure.
No, this is really great. And David, you did it, man. You got us all together.
Yeah, incredible.
So, hey, I have a question. So
Yeah.
I'm going to be doing a keynote, and when it's my turn, how do I do this?
You have to share a screen and you can do it. It's very easy, no worries. But now you can not to do it because I am sharing my screen. And before we start, I want to say hello to Dr. Melina Correa.
Hello, how are you?
How are you?
Hi, nice to meet you, Melina.
Thank you so much for being here also. So.
Thank you very much for the invitation. I think this meeting is amazing, amazing idea.
Thank you guys. Okay, I'm gonna leave you with, let me see, we're all here. I'm gonna leave you with David. David will be the moderator today. So, David.
Thank you, Andres. Thank you for the invitation and thank you everyone. If I don't know if somebody doesn't quite grasp what we're saying right now in the presentation, pueden anotarlo ahí en los chats. Con todo gusto vamos a estar hablando en inglés, español, portuñol, portugués un poquito. It is, feel free to, this is among friends and feel free to experiment. This is the place to do it. And I'm more than happy to present to all of you almost 500, 600 people that are already in tune that these are my great friends, my great colleagues. They are phenomenal ocular oncologists. My mentor, Dr. Carol Shields. I cannot synthesize into one sentence how grateful I feel for her to accept this, to participate in this panel. This is for the greater good of all ophthalmologists that are in America. And, it's a continuing education that sometimes people find it very useful. And I think we're benefiting a lot of patients, and that is great. So each and every one of us should really hug ourselves because this is absolutely wonderful that this is happening. So thank you for believing in this, and thank you to the panelists. I would like to give a brief description of who everybody is Dr. Carol Shields, like I said, she is one of the most renowned ophthalmologists to date, and she and Dr. Jerry have both changed ophthalmology forever, and you know, and giving us all this knowledge on ocular oncology. More than 3,000 articles are on PubMed, are the real background for all the work that she has put through, and her center, being the most important, or one of the most important ones in the world, has provided with a lot of information. Dr. Lauren Dalvin, she's one of our young promises, and she took a great responsibility with Mayo Clinic, and I'm sure that Mayo Clinic is very fortunate to have her there, and she will come and do great things. Her articles are super interesting. She writes super good, and so it's somebody to look out for. Dr. Basil Williams, he's a wonderful ocular oncologist, wonderful person, retina specialist. I cannot even start. He is absolutely wonderful. He has brought us a lot of information on how they do stuff in both Bascom Palmer, and put it together with what they do in Wilsai. So him and Maura Di Nicola are both are gonna, I'm sure, gonna do great things together, and I'm more than happy to have him here. And finally, Dr. Melina Correa, she is an institution in Sao Paulo in Brazil and on ultrasound, and I am more than happy to learn from her everything that she has to present to us about ultrasound. So having that brief introduction, I would like to see how we're going to organize this today. If you help me out, Andres, of how we set the program for today. You are mute.
Wait. Okay. Wait. Let me share my. Oops. My screen. Give me 1 sec, please. Here. What? Can you see, David, the program?
Yes. So I don't know if you want to go through it, but first of all, you know,
go ahead. Go ahead.
Dr. Melina Correa from Sao Paulo, Brazil. She will be giving us an introduction on ocular ultrasound. So this is a great area for ultrasound experts that are here today. Then Dr. Carol Shields is going to talk to us about pigmented tumors of the conjunctiva. Whenever we are going to find this at least once in our lives as ophthalmologists, as Dr. Shields is, I'm sure will tell you, this is far more common than we think, and we're going to learn to differentiate benign from malignant tumors. Then Dr. Basil is going to bring us all the new things on, you know, biopsy techniques. As a great retina surgeon, he will, I'm sure he'll tell us a lot about, you know, tips and tricks and all that. Then I will be talking about retinoblastoma, really trying to synthesize into the most important parts of the know-hows of retinoblastoma. Then finally, Dr. Lauren Dalvin will be talking about Nevis versus melanoma differences and the new things that have been published about possibly nomograms and that. So, este es el programa para los que hablamos español. Entonces, primero ultrasonido, después vamos a hablar un poco de conjuntiva, luego técnicas de biopsia, luego retinoblastoma y luego nevos y melanoma. Como ven, esto ha sido un programa diseñado con los temas más importantes de oncología ocular que podemos encontrar en nuestra práctica diaria. Entonces empezamos. We will start with Dr. Melina Correa, and if you want to log in your presentation, Dr. Melina.
Yes, let's see. ¿Pueden ver? No.
Hasta ahorita no. En compartir pantalla abajo.
Sí, pero... Está como falla aquí.
Abajo, Doc, you can share the screen.
Sí, pero no va. No sé qué pasa. Está como falla en la inicialización de share screen.
Andrés, ¿podemos pasar al siguiente ponente tal vez para...
Sí, claro, sí, sí.
Sí,
Let's
entonces
go
tienes
ahead with
el,
the speaker.
sí, el programa.
Sí.
Okay, well, we deal with some technical issues we're gonna go again to the next speaker, so that will be Dr. Carol Shields with pigmented tumors of the conjunctiva. Vamos a, mientras solucionamos los problemas técnicos, vamos a escuchar la presentación de la doctora Carol Shields acerca de los tumores de conjuntiva.
Dr. Shield, whenever you want, you can share your screen and you will be ready.
Okay, do I have to click on my screen or just put my slide up?
Okay.
So you would have to click on share screen and then pick the program.
Thank you.
Mm-hmm.
Okay, and share. And then I put my keynote up.
Yes.
Is that up?
Awesome.
Yes, we see it,
Yes.
although it's the financial disclosure slide.
Yes, is that good for you?
Yeah, we see it very well. Mm-hmm.
Okay. Yeah, so I have no financial interests or relationships to disclose. I'd like to speak to you about pigmentation on the conjunctiva, when to worry. I work on the oncology service at Wills Eye Hospital in Philadelphia, Pennsylvania, and I've had a wonderful year with David Ancona when he was a fellow with us. Thank you for inviting me. So there are several different conjunctival melanocytic tumors. Most of us are familiar with complexion-associated melanosis. We call that CAM. But there are other pigmented lesions like primary acquired melanosis, known as PAM, Nevis, melanoma, and even others like blue Nevis, secondary acquired melanosis called SAM, toxicities, melanocytosis, and masqueraders. Now, how common are these pigmented lesions on the surface of the eye? Several years ago, in 2016, we published an analysis of over 5,000 patients with conjunctival tumors. And in this analysis, we listed all the different types of tumors. And you can see in the red box, melanocytic tumors occupy over 50% of the conjunctival tumors that we see. So this is actually a very common part of our practice. The most common melanocytic tumors include Nevis, found in representing 23%, primary acquired melanosis representing 12%, and melanoma representing 12% of the cases we see. All put together, about 50% of all the cases that we see of conjunctival tumors. So I'll focus mostly just on these 4 different tumors so that you can sort them out. So when do you worry? Do you worry about CAM, complexion-associated melanosis? Nah, you really don't worry about that. How about PAM, primary acquired melanosis? We worry a little bit about that. Nevis? No, not so much. They rarely cause any bad problems. And melanoma? We worry a lot about melanoma. It is a very dangerous malignancy. So let's begin with CAM, complexion-associated melanosis. All of you in your practices see patients with complexion-associated melanosis. This used to be known as racial melanosis. If you look really carefully, this is different from PAM, primary acquired melanosis. You can see it has cobblestone microfolds near the limbus, and that's related to the blinking action of the lid, causing the pigment to shift and form these little microfolds. Sometimes there's fine pigment on the peripheral cornea. There can be forniceal extension, and it's pretty uncommon to see this involve the tarsus. And then one thing about CAM, complexion-associated melanosis, is it tends to be symmetric. So we manage this with observation. If the patient does not like the look of it, we will resect it or freeze it away. And some folks even laser it away. I issue caution. If you happen to see complexion-associated melanosis and it's very asymmetric, as shown here, you start worrying that this could be melanoma. And this is a real case of a 45-year-old African-American woman who came in with the right eye brown conjunctiva and the left eye clear conjunctiva, and it proved that the right eye had primary acquired melanosis and melanoma. So keep in mind, even dark-skinned people can develop melanoma and melanosis. Here's another asymmetric case in a 50-year-old African-American gentleman. If we pull down his lower lid, you can see a splotch of pigment in the fornix. Well, we removed that surgically, and luckily, it just proved to be a little bit of complexion-related melanosis. So just the fact that it's asymmetric doesn't mean it's going to be malignant, but it makes us a little bit more worried. Okay, so the second thing we want to talk about is primary acquired melanosis. If you can recognize this and know how to treat this or refer it when you find it, you can make a difference in a patient's life. This is a pigmentation that occurs in the conjunctiva in middle age, usually Caucasian patients. In nearly every case, I find it to be unilateral. It's flat, it has no cysts, but it does have a very real risk for melanoma. And look at the pigment. It's not the cobblestone-like pigment I showed you before with complexion-related melanosis. It's more of a peppery pigment. No cobblestones, no microfolds. It looks like a flat freckle on the conjunctiva. Here's another one. It looks a little peppery in its appearance. Well, PAM carries a real risk for the development of melanoma. Overall, based on two different studies, the Wills Eye and the AFIP study, the rate of melanoma in patients with PAM is 9 to 32%. Now, if PAM shows no atypia on pathology, the rate for transformation into melanoma is nearly 0. But if there is atypia on pathology, the rate is 13 to 46%. Now, I'd like to quote our figures because our figures represent clinical experience in over 300 cases that we published recently in this paper entitled Primary Acquired Melanosis of the Conjunctiva, Risk for Progression to Melanoma in 311 Eyes. Again, overall, the rate was 9%, if no atypia, 0%, and if severe atypia, 13%. Now I'm going to ask you a question. Can we predict which PAM will transform into melanoma? And the answer is yes. Size matters. The larger the size of PAM, the greater the risk. Every clock hour adds a 1.7 times greater chance for the development of melanoma. So keep that in mind. So if we see a patient with PAM and it's only 1 clock hour, as shown here, we're not going to be too nervous about that. We'll probably just watch that because the risk for melanoma is so little. But if someone comes in with PAM this extensive, 7 clock hours, that's a 7 times 1.7 hazard ratio. So that's a 12 times greater risk for melanoma. We will treat that, whether we treat that with surgical excision, keratectomy, cryotherapy and reconstruction, or maybe just topical mitomycin C. Here's a patient, an interesting patient who was managed elsewhere. He had PAM in 2016. It was removed, and you can see a nice surgical result. And then in 2018, it still looked good, but lift the lid, you can see there's melanoma under the lid. Flip the lid, you can see there's a nodule, and if you flip the lid, it's an extensive form of melanoma. Patients with PAM need to be monitored, not just the bulbar conjunctiva, but you got to look in the fornix and flip the lid and check the tarsal conjunctiva. Now, just a few words about Nevis. All of us are familiar with conjunctival nevi. They tend to be pigmented in 85% of cases, and 65% tend to show these clear cysts within Nevis. Now, here's a Nevis that has no pigment at all, but you can still see the clear cyst on the limbal side of this Nevis. Nevi tend to occur near the limbus, nasally or temporally. They're either on the bulbar conj, they can be in the caruncle or in the plica. But it's pretty, and you can see when they occur on the bulbar conj, they tend to be right up against the limbus. Now, beware the pigmented Nevis in the fornix, on the tarsus, or on the cornea. Got to rule out melanoma or primary acquired melanosis, because that's a very rare, those are 3 rare sites to see Nevis. Here's a patient we saw several years ago who had a classic conjunctival Nevis with cysts, But look what happened over the years. We saw this solid mass develop from the edge of the Nevis, and that proved to be a melanoma arising from Nevis. I don't worry much about nevi because the rate of transformation into melanoma is low, 1 in 300. So last, we'll finish up on conjunctival melanoma. Okay, now I'm going to ask you a question, and only Lauren Dowland knows the answer. Question number 1, what skin type is at greatest risk for skin melanoma? And these are the 6 Fitzpatrick skin types. Well, the answer is types 1 and 2. The lightest complexion people are at greatest risk for skin melanoma. But I must add, those with the darkest complexion have the worst prognosis because of late detection, because who would think that they would be at risk for melanoma? So my second question is, what skin type is at greatest risk for conjunctival melanoma? And based on a recent study that we did, it's Fitzpatrick skin type 1 and 2, the fair-skinned people. There's no difference in prognosis for conj melanoma based on your skin type. And we're publishing this in Ophthalmic Plastic and Reconstructive Surgery this year on the Fitzpatrick skin type and how it plays into melanoma. Basically, you want to look at those patients who are very fair skinned. They have skin type 1 or 2 because they most commonly display melanoma, whereas types 3, 4, 5, and 6 rarely show conjunctival melanoma. So here are the 6 skin types, type 1, 2, 3, 4, 5, 6, and every one of these patients had conjunctival melanoma. So I just encourage you, you still need to look at types 4, 5, and 6 for pigmented lesions, but it's less likely that they'll show skin melanoma. And here are those same 6 skin types, each showing the melanoma on the surface of the eye, even in patients with dark complexion. So the bottom line is your patient's complexion can be a clue to the diagnosis of melanoma. Now, I want to underscore how important it is to check all conjunctival surfaces. This patient was sent in with a plical nevus, right? Wrong. Flip the lid. That's a melanoma on the tarsal surface with a little tail into the plica. So we manage melanoma either with surgery for removal. Most often we use surgery for complete surgical removal. And the first surgery is the most important. We do no touch surgery, never handling the tumor, and we avoid tumor seeding. Use a dry environment, no BSS, because that can make cells float and then engage in new tumors. We do not want to have multifocal recurrence because that could lead to exoneration. So a tumor like this at the limbus, which is small, we would do complete surgical resection, never touching the tumor, and no BSS. Patient looks fine with a little bit of scarring at the site, and this patient has a good prognosis. Here's a patient with an amelanotic tumor. You might say, okay, just take that off. But no, you have to go one step more. You've got to take off all the PAM. You really have to inspect these patients to find all the primary acquired melanosis, because you don't want to miss that, because that will come back as tumor. And last, I just want to make a comment that operating on conjunctival melanoma is more than look and operate. Now we search for biomarkers, molecular biomarkers. They identify high-risk melanoma. We have medications against these markers, just like the skin melanoma doctors have. So the first report came out with Carol Karp as senior author, and they looked at 5 cases and found multiple mutations in conjunctival melanoma, most importantly in BRAF. And we now have medications against BRAF mutation. And last, I want to say a word about checkpoint inhibitors. Pembrolizumab and some of the other checkpoint inhibitors have become very important in the management of melanoma. Here's a case report from the University of Louisville, Aparna Ramasubramanian. She actually was a fellow with us. This is an elderly person who was not a good surgical candidate, so they put the patient on a checkpoint inhibitor medication, and the tumors completely resolved following several months on checkpoint inhibitors. So we're now using this for patients with extensive disease or orbital invasion. They biopsied that after treatment and it was complete necrosis. So when there's pigment on the conjunctiva, when do you worry? Well, you worry if it's melanoma and you worry a little if it's primary acquired melanosis. Just understand the importance of biomarkers for conjunctival melanoma. There's an evolving role now with checkpoint inhibitors, a new medication that your melanoma oncologists know about. And we now partner, every week, we partner with our systemic melanoma oncologists in the management of conjunctival melanoma. Thank you.
Wow, thank you for that
Thank
presentation.
you so much.
It was really great. Now, if you want to stop share, yeah, you're perfect.
Hey, David, I have a question for Dr. Shields, if I may.
Yeah.
Of course.
Hey,
Yeah,
Dr.
of course.
Shields, have you used map biopsies, or do you use map biopsies in all your PAM cases, or do you have any type of criteria where you use those type of biopsies?
So in the past, we did use map biopsies. Nowadays, we don't map quite as much. The only malignancy that we really feel it's important to map is sebaceous carcinoma that has conjunctival pagetoid invasion. We used to map primary acquired melanosis, but we don't do it anymore. We basically take a biopsy or completely excise it if we can, and then we do cryotherapy and we cryo all the areas of pigmentation. Now, the only time where we do consider map biopsies for conj primary acquired melanosis is those rare conditions where it's primary acquired melanosis sine pigmento, no pigment. There's a variant of primary acquired melanosis that's completely amelanotic, and the patients develop amelanotic melanoma, so you can't see it. Well, that's when we do map biopsy. But otherwise, if it's pigmented melanosis, we don't necessarily anymore. But thank you for the question.
Lymph node biopsy, do you do that as well?
Yeah, big question. Do we do sentinel lymph node biopsy? I mean, that's even debated in our dermatology literature. The dermatologists don't know if it even helps the patients, but we offer it to all of our patients. Any patient that has a conjunctival melanoma greater than 2 millimeters in any dimension, we offer sentinel lymph node biopsy, and we have our facial plastic or ear, nose, and throat plastic surgeon go in and do the sentinel node biopsy. We inject the radioactive dye, and then they go in within several hours and do the biopsy.
Thank you.
Yeah, you're welcome.
David, ¿quieres que continuemos? Doctor,
sí, lo que podemos hacer, Andrés, es que podemos reservar un par de preguntas por el panelista, por Hansel, y estas preguntas que están haciendo en el chat las podemos ir almacenando para responder al final por los panelistas, sí, claro, ya, para que tengamos oportunidad de escucharlos a todos. La siguiente presentación es por la doctora Melina Morales de la Universidad de Sao Paulo, Brazil. The next presenter will be Dr. Melina Morales. She will talk about ultrasound in intraocular tumors, and she practices in Sao Paulo, Brazil, and you're free to start, Dr. Melina.
Thank you very much. Now you can see the screen, right?
Yes, perfect.
Perfect. So I asked if it was better in English or Portuñol, y Portuñol was the choice, right? So, bueno, voy a empezar a hablar entonces un poquito de ultrasonido ocular en tumores intraoculares. Creo que el primer consejo que puedo dar cuando va a iniciar un examen es chequear si la lesión es sólida o no, porque a veces podemos tener un pseudotumor. Como por ejemplo en esta talla aquí, lo que vemos, si tenemos solamente una foto estática, podemos decir, bueno, puede ser una lesión en forma de domo, pero ¿cómo hacemos para saber si es o si no es? En el examen cinético, miren el video. Tenemos que pedir que el paciente mire desde un lado hacia el otro, desde un lado hacia el otro, y ahí lo que vemos es la movimentación del contenido de la lesión, la ondulación de la superficie. O sea, en este caso no tenemos un tumor, teníamos una colección de sangre de este paciente. Muy bien, entonces, si no es un pseudotumor, tenemos un tumor, vamos a empezar hablando del melanoma de coroides, que creo que es el tumor que más tiene características típicas que nos ayudan a reconocerlo en el ultrasonido. Aquí tenemos entonces la lesión típica de melanoma, es una lesión melanocítica con pigmento naranja de lipofucsina, muy bien delimitada. Y en la derecha tenemos también su ultrasonido muy típico también, que es que una forma de domo y con baja reflectividad interna, o sea, es una lesión oscura por dentro. Este es lo típico. Y conociendo lo típico en el ultrasonido, cuando tenemos una lesión más rara, por ejemplo, como esta próxima, y ahora no pasa. Aquí, esta lesión más rara, por ejemplo, muy extensa, que va desde la papila del disco óptico hasta la extrema periferia, con unas porciones amelanóticas, bueno, podemos hacer el ultrasonido para quedarnos más tranquilos cuanto a la investigación. Me gusta mucho esta foto en la derecha porque es la pieza de la patología y esta pieza nos enseña por qué estas características típicas pasan. Miren que el tejido del tumor es un tejido muy denso, las células son muy interconectadas, o sea que cuando la onda sonora pasa por el tejido del tumor, encuentra resistencia y va cayendo. Por eso tenemos una baja reflectividad interna en el tumor típico, como pueden ver en la foto de la izquierda, que es el ultrasonido. Sí, es una lesión bilobulada, no es tan común, pero como pueden ver, cada lesión, cada lobo es muy típico de melanoma. Tiene su forma de domo y la baja reflectividad interna. Y aquí al modo A, miren hacia abajo los picos en amarillo, pueden ver que tienen media baja reflectividad y van cayendo desde la superficie hacia la base de la lesión. Este es el famoso signo del ángulo kappa, muy característico de melanoma de coroides. Pero, ¿qué pasa cuando el tumor crece demasiado? Bueno, perdemos estas características típicas. Ahora tenemos una lesión más heterogénea, con partes densas y partes no tan densas, por la vascularización, por isquemia, por necrosis, pero ganamos otras características también que nos ayudan en el ultrasonido. Una de ellas es la presencia de vascularización interna en los tumores grandes, como pueden ver ahí, principalmente en la parte de arriba, un flickering, unas oscilaciones pequeñas y muy rápidas. Esta es la vascularización interna muy característica de melanoma de coroides. No es patognomónica, pero es muy probable que sea un melanoma de coroides. Y otra característica también, cuando el tumor crece demasiado, aquí tenemos un tumor en forma de hongo. ¿Por qué? Porque rompió la membrana de Bruch y ha crecido haciendo una forma de hongo. Tenemos aquí una lesión amelanótica, de mushroom shape. Y en el ultrasonido lo que vemos también es una perfecta forma de hongo. Pero chequen en la parte de abajo, toda forma de hongo tiene que tener en su base algo que era una forma de domo, porque todo melanoma empieza como una forma de domo. Aquí en este caso, por acaso, tenemos detrás de la esclera una placa de braquiterapia aquí con sementes de yodo que pueden ver porque este es un ultrasonido intraoperatorio. Esta otra foto me gusta muchísimo porque podemos ver el punto exacto donde rompió la membrana de Bruch y por donde crece el tumor para hacer la forma de hongo. O sea, tenía forma de domo, ahora tiene forma de hongo. Otra característica muy común del melanoma de coroides en ultrasonido es la excavación de coroide, que pueden ver en la línea roja, donde ven que la base del tumor es más oscura, esto llamamos de silencio acústico, en comparación con la parte sadia en azul, o sea, esta forma más de oscuro, más fondo, es la excavación de coroide, también muy común en ultrasonido. Y ahora voy a señalar también muy rápidamente las principales diferencias de algunos tumores en relación al hemangioma. El hemangioma, cuando no tiene exudación, es hasta difícil de ver al fondo de ojo por su coloración. Pero en el ultrasonido lo que tenemos también es un tumor en forma de domo, pero la grande diferencia para el melanoma es que su reflectividad interna es media alta, en cuanto del melanoma es media baja. O sea, el hemangioma, si podemos comparar aquí, a la izquierda tenemos una lesión más blanca, miren, los picos en amarillo abajo son estables y de media alta reflectividad. A la derecha tenemos el melanoma, que es más oscuro adentro, o sea, baja reflectividad. Y los picos amarillos abajo son de media baja reflectividad, cayendo, formando el signo del ángulo capa. Entonces, así diferenciamos muy bien con el ultrasonido un melanoma de un hemangioma, por ejemplo. El osteoma es aún más fácil en el ultrasonido. Como pueden ver, lo que vemos en el ultrasonido es una placa muy blanca, alta reflectividad, que hace sombreamiento posterior mismo en muy bajo gaño. Y finalmente el melanocitoma es muy fácil, sí, pero algunas veces cuando está un poco más grande como este caso y quedamos en duda si es o no un melanoma, bueno, el ultrasonido también nos ayuda muchísimo porque la característica es totalmente diferente de un melanoma. Como pueden ver, tiene muy alta reflectividad. Por eso el ultrasonido es un aparato de muchísima importancia para quien hace oncología ocular y también para quien recibe el paciente. Espero que tenga ayudado a todos. Muchas gracias por la atención.
Fenomenal presentación, Dr. Correa. Great presentation. By the panelists, Dr. Hansel, would you like to make one main question and then we'll leave the rest for the end of the talk?
Basically, Dr. Molina talked the basics of everything. So if we start talking about ultrasound, we will extend 3-4 days talking about ultrasound alone. So thank you, Dr. Molina, for that.
I agree.
Thank you.
Do you have the program, Andres? Would you stop?
Yeah, the next one is Dr. Williams will be the next speaker. Basil, are you there, Dr. Williams?
Yes. And I think, okay, there we go. So
let me tell you to all the doctors that we are already 800 people listening and learning with you, doctor. So this is amazing.
It is
We're very happy.
Let me just introduce Dr. Basil Williams. I think you have,
yeah.
We are seeing the presentation. Do you want to switch to the, we're seeing the presenter's view. While Dr. Williams is switching that, I would like to introduce him. He's a wonderful ocular oncologist. He is in charge of the ocular oncology department in University of Cincinnati, also in Northern United States. And oh, hi, Dr. Jerry Shields. He's over there. We can see him there. Hello, Dr. Jerry.
Which, what are you seeing now?
Right now we're seeing you.
Yeah.
Okay. Is it?
If you want to switch, we still don't see your
you have to share the screen, basically. Yeah, and then you have to go down and. Okay.
Can you see my presentation now?
Yeah, we can see it, but in what is this?
I think if you click in the upper left corner where it says use a slideshow, you can change.
Right on the top left, Basil, where it says swap displays.
Okay.
Top left.
Swap displays. Yeah.
Swap displays.
How about now?
Yeah.
Oh, perfect. Awesome.
Perfect, Basil. Then
you,
again,
Basil.
Dr. Basil Williams es la cabeza de la Universidad de Cincinnati. Él habla muy bien español, a pesar de que le da un poquito de pena hablarlo. ¿Verdad, Basil?
Oh.
Y él, vamos a aprender mucho de esta práctica que es muy grande. Hay muchos, tienen muchos pacientes una experiencia de muchísimos años. Entonces, pues emocionado de lo que podemos aprender.
Hola a todos y gracias por la invitación. Thank you, David. I'm happy to be speaking here with both you and Lauren, previous co-fellows of mine, and Dr. Carol, previous mentor of mine. So it's truly an honor. And I'm going to talk a little bit about some of the biopsy techniques that you have in ocular oncology. I have no financial disclosures. So just a quick background. When you look at fine needle aspiration biopsy for intraocular tumors, this was introduced back in the late 70s. Now we know from the COM study, at least on large size lesions, that the diagnosis of uveal melanoma is pretty accurate based on clinical and imaging characteristics. However, there are still some scenarios where diagnostic dilemmas may require you to obtain cytopathology. But more commonly these days, biopsies are used for prognosis in uveal melanoma for patients to understand what their chances of metastasis are in the future. And so this can be done looking at the DNA or looking at the RNA characteristics. Now, it's a pretty safe technique with self-limited side effects, and we're going to kind of go into that. But there have been some cases reported of extraocular extension and possibly orbital spread, which can lead to early mortality. And so we're going to kind of go over some of the techniques that help to limit these complications. All right. So for techniques, there are two approaches. You can either go with an external approach, which would be transchleral, or you can go with an internal approach, which is a transvitreal approach. Now, when you think about this, sorry, okay. Can you guys still see my screen here?
Yes.
Okay, so when you think about this approach, using the transchleral or the external approach, it's a little bit of an easier technique. Because you get direct access to the lesion and you don't have to use the indirect ophthalmoscope or use the microscope. However, it can be, because you're going directly into the lesion, there is possibly a little bit of an increased risk of extraocular spread. When you use the transvitreal approach, which we prefer to do, and that is at least in large part due to my training in Philadelphia, we prefer to use the transvitreal approach when possible because it reduces the risk of extraocular spread. And I'll go into these techniques a little bit more. Okay, so first, using a transchleral approach, you can use either a 25 or a 27 gauge needle. You use transillumination, where you take a bright light, put it on the side of the globe, and you can identify the boundaries of where the lesion is. And then you can mark those boundaries. Then you can enter the sclera at about a 30-degree angle. And then when you're done, as you're withdrawing, you can put cryotherapy at the site of withdrawal to reduce the risk of extraocular extension. Now, there are a couple of techniques or approaches, and this is kind of the approach that we used when I was in Philadelphia and also what I use still in practice in Cincinnati. However, I have a video here from what is done in Duke in the way they perform their transchleral biopsies, where instead of going directly across the sclera, they use a blade to dissect down and make a partial thickness groove in the sclera, and then they put the needle biopsy into the thinner part of the inside part of the sclera, with the thinking being that whatever cells come outside at this point will be trapped in the sclera. Now, when you're doing this technique for cytogenetics, you're going to be putting a plaque on usually directly afterwards, and so that would neutralize or radiate whatever cells might be there in the sclera. If you're doing this for cytology only or cytopathology to obtain the accurate diagnosis, then it is probably ideal to put cryotherapy on immediately afterwards, which is what we do for standard practice. And you can see in the hub of the needle, you can see some what appears to be pigmented cells. And if you do decide to use a cut down, it's a good idea to then suture that wound. Now, one thing to note about transchleral biopsies, lastly, is that these often in the literature at least have a higher success rate, but that is probably more due to the fact that these are done on lesions anterior to the equator, and by the time they're diagnosed, they're a little bit thicker in size. And so it's easier to get the needle into a thicker lesion and get a higher yield. Now, next, switching over to an internal approach, when you go through a transvitreal approach, there's a number of ways that you can do this. You can do this with a fine needle aspiration biopsy. That could be done with or without a trocar, and it can be done with or without the microscope. You can also use a vitrector-assisted approach, which we'll talk about a little bit later. So when you're using the fine needle aspiration biopsy, you want to go through the pars plana so you can mark your area 3.5 millimeters posterior to the limbus. And the more challenging technique, at least it takes a little while to get comfortable in the beginning, is using indirect ophthalmoscopy in order to do the fine needle aspiration biopsy. Now, everything there is upside down and backwards, so it definitely takes a little getting used to in order to do. But you want to go through the pars plana in the meridian of the tumor. That way you don't have to move a lot left to right in order to find the tumor. After you do your aspiration through the syringe and some connection tubing, when you're getting ready to withdraw, you want an assistant to use aggressive depression at the site of the biopsy in order to achieve hemostasis. And if you need to, you can add some BSS in the anterior chamber or in the vitreous to resolve any hypotony that's there. Now, it perhaps is a little bit easier if you use a microscope, and I'm going to show a video, again, out of the Duke group using a microscope for the fine needle aspiration biopsy. And again, you mark your area. You can see that they have a chandelier light, and they use the fine needle, and you can come across the eye in this scenario to go into the tumor. This is a little bit easier to do because it's a direct view, but it is perhaps a little bit more costly and maybe takes a little bit more time because it requires you to get the scope set up and to open the chandelier. And then again, after you withdraw the needle, you press with a cotton tip to achieve hemostasis. So next, you can use a vitrector-assisted biopsy, and this you often will use a standard 3-port pars plana vitrectomy setup where you have your infusion line primed and ready, but you do not have it on. You can also do this without the infusion line if you want. When you're using these settings, you want a low cut rate and high aspiration. And basically, you're ready to kick up the pressure on the foot pedal to about 60 millimeters of mercury immediately after the biopsy or sometimes before to reduce the bleeding. And here's a video from one of my colleagues and mentors when I was in Miami, an ocular oncologist in Puerto Rico, Victor Villegas. And using the vitrector-assisted approach, you can see there's a pretty large tumor here. And then we'll show a little bit around the eye. You can see there's a significant exudative detachment. And you can go all the way into the tumor, and you can aspirate and cut until you can see pigmented cells actually coming into the line. Now, the advantage of doing a vitrector-assisted approach is that you can do this by yourself without an assistant. So it's a little bit easier to do from that respect. However, again, it is a little bit more costly and it is a little bit more expensive to do. From a complication standpoint, vitreous hemorrhage is the most likely complication that you'll get, ranging somewhere from 15 up as high as 90%, but that depends a little bit on the technique. If you're doing a vitrector-assisted approach, you probably are more likely to get some hemorrhage. Maybe that's because you're getting more intratumoral vessels, or maybe it's because a lot of time when you're using a vitrectomy setup, you're seeing the patient a little bit earlier. Maybe post-op day 1, the hemorrhage is a little bit more common. But most of the vitreous hemorrhages are transient. And here's a case that we all participated in as fellows in Philadelphia, where a patient had a biopsy. 3 weeks later, you can see the view is a little bit hazy from the hemorrhage, but by 3 months out, the hemorrhage is completely cleared. And so that's most commonly what you're going to experience when you get a hemorrhage after the biopsy. Another complication that you can get that is quite a bit more rare is retinal detachment. So it is very rare, but it does happen, and it's something that you should talk about with your patients. Again, another case from fellowship, a patient who we biopsied for cytology, turned out to be a Nevis, but they did develop a retinal detachment, had successful retinal repair with vitrectomy. And so even though this happens much less than 5% of the time, it's good to let your patients know that it is possible for this to happen. Really, extraocular extension is possible. Again, that's shown by a couple of case reports, but the chances of it happening are so low that, as long as you use appropriate techniques, it is a pretty safe procedure. So in conclusion, intraocular biopsy can be used for cytopathology or for prognostic assessment. The transchloro and transvitreal approaches can be used. Transchloro primarily for anterior lesions, anterior to the equator and the ciliary body, and a transvitreal approach posteriorly. Postoperative complications are rare and often transient. And I'd like to thank Dr. DiNicola, my partner in practice, who was also a fellow with all of us, for her help putting together this presentation and helping to manage all of the patients that we see in Cincinnati. So once again, thank you for the opportunity to talk with you today.
That was absolutely wonderful, Basil. It was a great talk, really informative for both ophthalmologists and ocular oncologists. And while you log off, we see Dr. Jerry Shields that just popped into the into the webcam. I don't know if you would like to say hi to all Latin America over here, Dr. Shields. Maybe practice your Spanish a little bit. You have your microphone on.
Say hello to everyone.
Hello there. How's everybody doing? Thanks for a great talk.
Truly great to have you here, Dr. Jerry. It's such an honor. Hope you like the next presentation. It will be on one of your favorite topics, which is retinoblastoma. So hope you can stick with us around here. So next presenter is me. I will switch my screen. Hope you guys can see. All right, I'm gonna turn everything else off because otherwise I'm not going to be able to see. And I will be talking about retinoblastoma today, and I declare no financial interests. However, some of the slides might discuss some copyrighted material or articles that are still in press. So I would like to take that into account. First of all, if we go back into history, we can learn from history. Dr. Bartish was the first one to remove an eye from a patient in ocular cancer. If you notice, that had ocular cancer. If you notice, it was back in 1583. So if you see what was happening around that era, Cervantes was still to write Don Quixote for all the Spanish speakers over there, and Galileo was just seeing the moons of Jupiter. So imagine and we were already treating patients with ocular cancer back in the day. There's even descriptions of, now will be debatable that were large and repulsive. We don't say that anymore, but basically these are treatments that were done back in the day. Eran tratamientos que pudieron haber estado un poquito ya en desuso. ¿Qué estamos haciendo diferente en retinoblastoma? What are we doing different in retinoblastoma? So today I will talk about Legos, not so much about retinoblastoma. El día de hoy voy a hablar un poco de los Legos. No hay disclosure, no me están pagando nada por decir esto, pero todo lo vamos a hacer un poquito más dinámico y divertido. Primero que nada empezamos. First of all, we'll start with the ICRB classification that was put together with the help of Dr. Shields, and they assess intraocular dissemination. So first we have the small group A, which is small retinoblastomas. That means less than 3 millimeters. We have bigger retinoblastomas, more than 3 millimeters or closer to the optic nerve or foveola. We have C, which are close seeds that are in close proximity to the tumor, less than 3 millimeters. Diffuse seeding, that is, they're a little bit farther away from the tumor. And finally, we see extensive, which is more than half of the globe, or that would have another complication like neovascular glaucoma. So what are our goals? The mission objectives of retinoblastoma keep being protect life above all. Next are saving the globe, and lastly, optimize vision. We are never ever going to risk life, and this is very important, and that's our top priority as oncologists. So we have many things to treat retinoblastoma nowadays. We synthesize it very well in an article that I will be presenting you later. But we don't. It might be a little bit confusing what to use and when. Like, it gives you a little bit of frustration to have that many options. Nos da un poco de frustración. Entonces, what are we going to do is we're going to synthesize this very well. I don't think so. This is not going to cause us frustration, and this is going to be very simple. So coordinated by Dr. Shields in Philadelphia and with the help of both Lauren Dalvin and myself, we came together and tried to synthesize into a simple article what the modern and current treatment of retinoblastoma is. And we tried to see what we're doing correctly and what we're doing together. So it's a paper that you could look out for that is coming really soon. In it, we will present, en él vamos a presentar el algoritmo de tratamiento del retinoblastoma. Esa es la primera vez que se va a presentar algo así, en el cual se sintetiza el tratamiento del retinoblastoma y cómo es que lo hacemos. First of all, you would like to know that above everything, before deciding if it's unilateral or bilateral, you would have to do an initial examination, which first involves an under anesthesia examination and an MRI. An MRI is very important because you want to know if the tumor is intraocular or extraocular, because the treatment will be vastly different. El tratamiento va a ser muy diferente entre si es intraocular o extraocular. Entonces, lo primero es pedir una resonancia magnética y luego una examinación física de todo por el oncólogo pediatra. Después, after all, if it's unilateral, you will treat accordingly. If it's bilateral, you will treat that way. This is only a suggestion. This is how we work in our centers. This by no means it's a way that everybody should do that, but I think it helps to show how we do things and possibly help other referring doctors or doctors that treat these kids. So intravenous chemotherapy, normally we use from 2 to 4 drugs, and in a monthly administration of 6 to 9 cycles. I will say they use BEC, which is being Christian etoposide and carboplatin, also in Mayo Clinic, and also in Monterrey we use this. And after, we typically help to reduce the tumor further with the use of thermal or cryo. And we know that it's quite effective for intraocular tumors and to prevent metastases, which is why it's far more important in bilateral tumors and for pinealoblastoma prevention. And however, it has some risk, which could be pancytopenia and some nephro or ototoxicity. And this summarizes pretty much the talk. And we know it's effective. It can be very, very impressive, and it can achieve tumor control. La piste de resistance is the intraarterial chemotherapy because it's what has changed retinoblastoma from the old days to the newer days. And it consists of bringing a catheter up to the ophthalmic artery and give a 10 times higher dose of chemotherapy agents to the ophthalmic artery. So this is designed for big tumors. This is for advanced disease, and normally it would have a good penetration to the tumor. So normally we use melphalan or topotecan. This happens in both Wills and Mayo Clinic, and also here in Monterrey. And normally it's a 30-minute infusion of the drugs. And normally from 3 to 4 infusions are the ones that we require. And there have been some extraocular complications associated. However, most of them are temporary. And by an article that we put together, we know that the intraocular complications are quite rare, less than 20%. However, when they occur, they are really catastrophic for vision, which is the most frequent one, ophthalmic artery occlusion. If we put things into perspective, we're still treating the tumor, so it might actually be a good option for many, many patients. So we know it's effective, as here are some images of intraarterial chemotherapy being in action. We know it's quite potent. It is not experimental. It is already treated. It is the treatment of choice in many centers like ours. So this is inspired by Dr. Carroll's presentation in PAO in the Pan American. I think it's inspired by her. So when we have unilateral retinoblastoma, we're going to choose intraarterial chemotherapy as our champion, because it's going to deliver quite a dose without the other risk factors. However, if we have bilateral retinoblastoma, possibly intravenous chemotherapy will be our treatment of choice, because it will not only help us to acquire good concentration, but also would help us in the prevention of pineoblastoma. This is what we do in Monterrey. This is our team, and those are our indications. So we pick children that weigh more than 6 kilograms, and because of the size of the ophthalmic artery, if they weigh less than that, then we choose bridge therapy, which is to give intravenous chemotherapy first and then switch to intraarterial chemotherapy. And those are the groups that we treat with this therapy. So this is the ideal patient for intraarterial chemotherapy: unilateral retinoblastoma with advanced stages, or if there have been failure to previous therapies. Intravitreal chemotherapy, I just want to say, due to time constraints, that this is not a first-line therapy. This is used as globe salvage. That's the only thing we need to know for now. And this the technique is very well described, and we see that it's very very effective. And also, there's other treatments like brachytherapy, which is also for recurrences, and radiotherapy, which is no longer a choice because we have safer, newer alternatives. It has although it's very highly radiosensitive, it has many important complications like secondary cancers. This is the before and after. I like this image a lot. Dr. Shields has presented it herself, and it's by an article by them in the JAMA Ophthalmology journal. And it's the before and after, both a mom and a kid with retinoblastoma. They were treated how they're treated back in the day and how they're treated nowadays. And despite them having the same pathology, they're doing vastly different. And the mom had 2 sarcomas, I believe, in the head, secondary to the EBRT. And now we see that that is no longer the reality right now. So then again, I would like to present to you the treatment algorithm for you to have if you want to have it over there. And that this is multidisciplinary, that enucleation is still an option, especially for low resource patients. So, and that is very important to keep giving prosthesis to these kids. And I want to highlight that mental health is very important for those children. This is what we're focusing on right now with our psychiatry team. And this is they're going through a duelo. Es un duelo. They're going through something that is abnormal for the family, and it really helps a lot. So this is, thank you for everybody for sticking up to our presentation, and obrigado. Gracias. Andrés.
Muy bueno, David. La verdad, impresionante. Congratulations, David. An incredible talk. I don't know if Hansel, do you have any question of the people you wanted to ask something?
Well, I have 2 questions.
Go ahead.
One for Basil, if you don't mind. We approach this right now. So when you are doing transscleral biopsy, do you prefer using do you prefer flap or no flap? Because I don't know if using a flap in this technique is very useful or just a waste of time.
Yeah, I think it's a really good question. And I think a lot of it depends on the comfort of the surgeon. So I normally do not use a flap. I normally go directly across the sclera and do cryotherapy as the needle is coming out to freeze whatever cells are there. There are definitely people that use a flap and feel more comfortable doing it. And so I agree with you that it takes a little bit more time. I'm not sure that there's clearly a right answer or a best way to do it, but I prefer to do it without the flap.
Thank you. And the other question is for you, David. Yo creo que puedo hacer esto en español, ya que somos contemporáneos ahí en eso. David, ¿has tenido algunos casos en donde pacientes que has tratado con melfalán intravítreo han desarrollado algún tipo de heterocromia del iris?
Más que he tenido, hasta este momento no, porque lo usamos para salvamento ocular. La heterocromía del iris después de melfalán intravítreo lo podemos observar sobre todo en iris hipopigmentados. Lo que es más frecuente es encontrar mucha atrofia, entonces esperaría encontrar atrofia del iris, y atrofia coroidea y atrofia del EPR. Y eso sería lo más importante, ¿no? Entonces, existe una muy buena, no, que yo sepa, no hay un artículo que se enfoque en esto, pero definitivamente me preocuparía encontrar algún tipo de atrofia en el iris. Sin embargo, cuando ponemos todo en perspectiva, pues es posible que si de eso dependía salvar el ojo, que pues sea algo manejable.
Gracias.
David, if you agree, we can continue with Dr. Lauren, the last talk, the last lecture.
Of course. Next up is Dr. Lauren Dalvin from the Mayo Clinic. She's the head of the Ocular Oncology department over there. We'll be happy to hear her presentation. Please stick with us, and after this, we're going to have the questions answered. So please stick with us. We're almost there. Thank you.
Thank you so much. Can you see my slides?
Yes. Yep. Perfect.
Perfect. Thank you so much for having me. I'm going to talk about choroidal nevus and choroidal melanoma. Where do we draw the line between these 2 conditions? So choroidal nevus is probably my bread and butter. This is a very common benign primary intraocular tumor. We see this in about 1 out of every 10 Caucasian adults. They tend to show up around puberty, and they're typically referred to the oncology service around middle age and when these are a little bit larger than 5 millimeters in diameter. Most choroidal nevi are pretty thin, less than 2 millimeters thick, but of course we worry about these because they have a risk for transformation into melanoma. So choroidal melanoma is the most common intraocular malignancy that starts primarily in the eye. It affects about 6 in a million people in the United States, and it's more common in Caucasian individuals. So here in Minnesota, where we have a lot of Scandinavians, I see this quite a bit. Other risk factors for this include, of course, the presence of a choroidal nevus, ocular melanocytosis, and dysplastic nevus syndrome. And choroidal melanoma is a very serious cancer. This can come with risk for loss of the eye. It can spread to other places in the body, most commonly liver and lungs, and it can result in death. So some of our really high risk tumors actually have a greater than 50% chance of spreading to elsewhere in the body within the first 5 years. Sometimes it's easy to find melanoma. As Dr. Correa showed us, mushroom tumors are classic for melanoma, but sometimes they're a little more subtle, and we really want to catch them when they're here, when they're small. Early detection, we know, portends a better prognosis for these patients. Larger tumors are much more likely to have those high-risk cytogenetics that, like Dr. Williams talked about, we can detect with our biopsy samples. And we know that growth really increases the risk for cancer spread. We can see here, if we detect these when they're small, they have a pretty low chance of metastasizing, but large tumors can really be bad news for our patients. So how do we find these early? You may be familiar with our clinical risk factors by our mnemonic to find small ocular melanoma using helpful hints daily. And that stands for tumor thickness greater than 2 millimeters, subretinal fluid, symptoms of flashes and floaters, orange pigment, tumor margin close to the optic disc, hollowness by ultrasound, and protective factors of a depigmented halo around the nevus or drusen overlying our nevus. But we've actually had a chance to update these risk factors now based on multimodal imaging features. And so some of the things we use, we've talked about in detail today, like our ultrasound. Ultrasound lets us measure the thickness of our tumor, and it lets us tell, is this tumor dense, such as this one, white inside, or is it hollow, dark inside? And that corresponds with our A-scan high and low internal reflectivity. We also use autofluorescence. This can help us detect that orange pigment. So sometimes it might be obvious like this in a pigmented tumor, but if we have something amelanotic, there's almost this brown coloration to our orange pigment that lights up so much better for us on autofluorescence imaging. We know that OCT has been really helpful in detecting subretinal fluid, so we can get nice cross sections through our nevi. We can detect really thin caps of subretinal fluid that we probably couldn't see clinically. So we've put these all together and come up with a new mnemonic to find small ocular melanoma doing imaging. So this stands for, again, our thickness greater than 2 millimeters. F is still for subretinal fluid. Symptoms now are visual acuity loss to worse than 20/50. O for orange pigment. Our M is for melanoma acoustic hollowness by ultrasound, and DIM for diameter greater than 5 millimeters. So a couple of things have changed. Symptoms are no longer subjective flashes and floaters. We now have objective visual acuity. Margin close to the disc was no longer a significant factor, and that may be that we're getting better at detecting these very peripheral nevi as our imaging has evolved. Drusen and halo are no longer protective factors, and our diameter larger than 5 millimeters is a new risk factor. So we can actually give a risk for 5-year growth based on each of these individual risk factors. And some of the really important ones are thickness, which gives us an 8-fold increased risk for growth, and orange pigment, which at 5 years has a 37% chance of growth to melanoma. And that's just as a single risk factor alone. As you might expect, if we have more than one risk factor, we have increased risk for growth to melanoma. And we wrote a nice paper at in the British Journal of Ophthalmology, where we have some figures where you can actually pinpoint exactly what is the 5-year risk for growth for your patient, depending on exactly what combination of risk factors they have. So just a couple of examples, because pictures are always nicer than words. Here we have a pretty small choroidal nevus. There's some overlying drusen on our OCT, but no fluid. We don't see any orange pigment, and it's relatively flat by ultrasound. So this had no risk factors and remained stable over time. Here we have a larger peripapillary nevus, and we can almost see clinically some orange. There's definitely subretinal fluid. Our autofluorescence confirms that there is orange pigment, and it's a little bit hollow on our ultrasound. So this over time with 3 risk factors did grow into a melanoma that required treatment. A couple of other examples here. Sometimes we can have really subtle growth. This is a patient that I'm going to be seeing soon in my practice that was referred due to concern for some change in this lesion here. So we look at this and say, okay, it's probably a little larger than 5 millimeters. We don't really see any orange pigment. We can see some overlying drusen, but no subretinal fluid. And it's a little hollow on ultrasound. Over time, we can see some really subtle change, that there's been just a little bit of expansion of the margins, and it's just a little thicker by ultrasound. So in these cases where there's some really subtle change, we have to ask ourselves questions like, how long did this occur? So the first picture was taken about 5 years ago, and this one is today. So this could have been slow growth over a long period of time, but these are tough situations where you definitely want to get your experienced ocular oncologists involved. Here's another patient with an amelanotic lesion that we've been following for a long time. You can probably tell that ultrasound looks like it's a little outdated. So again, this is going to be a larger size lesion in terms of diameter, and there's a good amount of fluid overlying that. So we might have been a little bit worried about this lesion, but this has actually been pretty rock solid stable for 20 years now. And finally, here's another amelanotic lesion. This will help us practice picking up that brown orange pigment. Now you can see it pretty clearly here. This again is a little bit on the larger diameter side. It's got some subretinal fluid and it's hollow. So this definitely has grown, and this has grown in a short period of time, just 6 months. You can see it's expanded and become thicker. So this is a patient who's going to require treatment. So on the bright side, we do have good treatment modalities that we don't have time to go into detail with today. Some patients may still have to have their eye removed for large melanomas, but if we're lucky and we catch them small, we have excellent radiation therapies and even newer things like nanoparticle therapy on the horizon. So here we have our mainstay. Plaque radiotherapy is probably the most common thing I do, and we have all different shapes and sizes to fit many of our tumors. And we can also do things like gamma knife and proton beam, where we can place fiducial markers to kind of size out our tumor and treat these patients with globe-sparing therapy. So in conclusion, early detection of choroidal melanoma really improves prognosis. And we can use both our clinical and now our multimodal imaging risk factors to help us pick these up early. Thickness and orange pigment are going to be especially important things to pay attention to in your patients. And the more risk factors they have, the more concerned we should be. Any patient who's into that 3 or more risk factor range should probably see an experienced ocular oncologist. And of course, if you're ever in doubt, we are always here to help you. So thank you again so much for having me. It's really a pleasure to be here with all of my good friends and mentors.
What a great talk. Thank you, Dr. Dalby.
Thank you, Doctor. Amazing talk. Amazing talk. Okay, we can start with questions of the assistants, Hansel, David, whatever you want. This is the time. This is the moment for you guys.
David, te doy la palabra a ti.
Gracias, Hansel. So there was a question for Dr. Shields over there. It would say, it is regarding conjunctival tumors. It says, how should the excision be done on the cornea? How deep can we go in limbus and cornea into the sclera? And this is by an anonymous spectator.
Yes, so basically when we remove the corneal component of a melanoma, we know that it is held very superficially within the epithelium of the cornea. Very rarely does it go deep to Bowman's membrane. So we don't dig deep into the corneal stroma. We basically apply absolute alcohol to the cornea, and we carefully scroll off the corneal epithelium, taking great care to not scratch or damage Bowman's membrane, because it is super rare for melanoma to grow beyond Bowman's membrane. So in answer to the question, we stay very superficial, and most of the time we don't damage the cornea, and we don't even dig or dive into the stroma. We stay very superficial.
So superficial is the choice. Thank you for that question. Again, for you, this question is by Dr. Alba. He asks if you would consider mandatorily removing any conjunctival pigmented lesion if you have a story of conjunctival melanoma in that eye.
Yes, so that's a great question. We tend to keep the conjunctiva as clean as possible if a patient has had previous melanoma. So in answer to that question, yes, we would remove all pigment, whether it be surgically or with cryotherapy or with topical mitomycin C. We prefer to have the conjunctiva clean if there's a conj melanoma.
Thank you, Dr. Shields. This question to Dr. Correa. Dr. Medina, ¿qué tanto perdemos utilizando el vector C en lugar del vector A, tomando en cuenta que la mayoría de centros no tienen la sonda de modo A estandarizada?
Bueno, can I speak in English? I think everybody's speaking English.
Yes, of course. I
think you can examine really well without the vector C. There's no problem. We can manage it really well. As you said, they don't have it in they standardize the echography in many centers. So with the B mode and the A vector, yes, we can do just fine.
Muchas gracias. Igual para usted, doctora, for you, Dr. Melina Correa, there was another question about how to differentiate between optic nerve drusen and melanocytoma for ultrasound.
The drusen usually is more deep in the optic disc. It's beneath the wall of the ocular wall. And the melanocytoma, you can see it's a little bit higher, it's over the papilla. It's more the localization, the location of the lesion.
Thank you, Dr. Correa. And I think the clinical image would also help you a lot.
One more tip. You can also see the shadowing it makes. The drusen makes a lot more shadowing than a melanocytoma. So you lower the gain in the drusen, you see there's a shadowing and not the melanocytoma.
That's a great tip. Dr. Basil Williams, this is a question for you from Dr. Ayala. He's asking what the percentage of tumor spread. I would think a bare estimate would be fine using the vitrectomy guided biopsy technique.
So the risk of extraocular extension is going to be less than 1% in the literature for sure. I am not sure that there is a reported case of extraocular extension using a vitrector where the technique was clearly identified. There have been some cases. There was 4 cases published by Amy Scheffler and company, but the technique of the vitrectomy at that time was not well described, and it might have been 20 gauge. So with small gauge vitrector assisted biopsy, I'm not sure that there has been a report of extraocular extension, and if so, it's extremely rare, so significantly less than 1%.
Thank you very much, Dr. Williams. That is great tips.
David, is here Dr. Rubens Belfort, Jr. Dr. Belfort, if you want to speak, please feel free to give us your opinions, your thoughts.
Yes, an authority in Brazil. Let's hear from him.
We know that your microphone it's open if you want to talk. Thank you. Just learning, he said. Thanks, just learning.
Thank you very much. It's great just to watch your presentations. Thank you so much for the opportunity to say hi. Carol, Basil, David, amazing. Thank you so much. I'll be quiet here and and just learn. Thank you so much.
Thank you, Ruben.
Thank you, doctor. Thank you.
So this is a question for Dr. Dalvin regarding choroidal nevus, peripheral choroidal nevus, where you cannot use OCT. It says, and the inconvenience of ultrasound that it cannot detect lesions below 2 millimeters. What do you suggest for peripheral nevus?
Yeah, that's a really good question. When we can't get good OCT images, and I have to say I'm really lucky I have amazing photographers who somehow get way out in the periphery, but definitely we start to rely more heavily on our ultrasound. Certainly you can be reassured if you get your OCT out as peripherally as possible that you're not missing a large pocket of fluid or something that's extending posteriorly near to the macula. So you can kind of reassure yourself that if there's fluid there, it's likely small in amount, but your ultrasound monitoring is going to be critical. And if you're dealing with something that's so peripheral you can't see the anterior margin on your exam, then it's probably a good idea also to monitor with UBM and make sure that you don't miss any ciliary body component. So that's going to be a regular, every 6 months or every year, depending on your level of concern, monitoring with both ultrasound and UBM for any growth.
Correct, because that could be the tip of the iceberg, right? If you cannot see the whole interior, it could be even a ring melanoma or something around that image, So that's great tips to use UBM. So if you want to see high resolution and you cannot see it, you can use UBM. On that same, this is another question on that same line by Dr. Galarza. So how would you treat leaky choroidal nevus, Dr. Lauren?
Excellent question. So some different things we can do for leaky choroidal nevus. Of course, number one, you want to be really sure that you're not dealing with a small choroidal melanoma, but things we can do if you're dealing with something that's peripheral outside of your macula, it's pretty easy to do PDT. Sometimes that will dry up some of the fluid. You want to be careful if you're doing that anywhere near the macula where you could potentially compromise vision. We can also try things like intravitreal anti-VEGF agents or steroid type of agents. And sometimes they're helpful, sometimes they're a little less helpful because probably fluid associated with nevus is less of a VEGF driven process. So you may have to be a little bit patient and try over time. If something is really asymptomatic, I'm much more opted just to observe and let it be, even if there's a little bit of fluid there.
Fantastic, I myself think so. And if it's not diminishing vision, then you can only observe. Man, Dr. Shields, Dr. Duarte is asking about suspicious melanocytic lesions in the caruncula. Do you have any tips for that?
Yeah, so 99% of any pigmented lesions in the caruncle will prove to be a nevus, but you don't want to get burned on that 1% that proves to be a melanoma. So in our practice, we tend to recommend that patients have pigmented nevi of the caruncle removed, because if it is a melanoma, that's a bad place to have a melanoma because it can grow deep, get into the orbit before the patient's even minimally symptomatic. So we tend to remove caruncular nevi, to ensure that it's just a nevus, B, to prevent the development of melanoma.
Thank you for that. There was a question also about, still for you, Dr. Shields. It says, please, after non-touch excision, cryotherapy, and cornea desepitalization with alcohol, pathology says that conjunctival melanoma, he's asking about cryotherapy, about brachytherapy for conjunctival lesions. When would you consider brachytherapy over mitomycin, or if you're using conjunction with mitomycin?
Yeah, so mitomycin is limited to treating surface epithelial lesions. So if you have primary acquired melanosis, mitomycin can be effective. Just caution, if you've just done surgery and the patient has PAM all over the surface of the eye, you want to wait until your wound is totally healed, like 4 weeks or 8 weeks before you start the patient on mitomycin, because you need your wound completely healed. If mitomycin gets beneath the conjunctiva, it can cause scleral necrosis. So we generally don't use mitomycin. In our practice for primary acquired melanosis, we most often associated with melanoma or not associated with melanoma, we most often treat it with cryotherapy more so than mitomycin C.
Thank you for that question. There's a question for me, for that answer, there's a question for me about, there's two questions, one by Dr. Alba that is asking about that if we have PDT here in Mexico, how, since we don't have PDT here in Mexico, how can we treat choroidal hemangioma? Well, there's several ways to treat choroidal hemangioma. It will depend on if it's diminishing the visual acuity. Another option would be to, TTT, I mean, although it could cause bleeding, or brachytherapy. So brachytherapy could be an excellent option. However, it could diminish, it has side effects like radiation-related retinopathy, and that would be a concern if it's located near the macula. There's another question that we know that there's intraocular chemotherapy that is getting strength in the retinoblastoma community. What do you think of the constant risk of reactivation of retinoblastoma? Do you know if reactivation presents, how many will end up in enucleation or worse with metastasis? So I want to highlight the importance of intraarterial chemotherapy. Again, intraarterial chemotherapy is not experimental. This is a therapy that is constantly used in all the centers, and you need to know that it's not for everything. Like I said, I think the algorithm will help on deciding which patients to treat with intraarterial chemotherapy. There's a risk for reactivation, most definitely within the first year, and we need to take care of that. And that's when intravitreal chemotherapy, intracameral chemotherapy, and precision intravitreal chemotherapy hop into place, because we can save many of those eyes. We would like to be cautious with bilateral retinoblastoma. That's where we observe most of metastasis. So that would be my answer. Thank you for that answer, that question, Dr. Salgado. And Dr. Trujillo, what is your, asks Dr. Basil Williams, what are your takeaway tips regarding endoresection surgery for choroidal melanoma? Is it something you do, you have tried? Is it something that, which is the ideal patient for this type?
Yeah, so I tend not to do primary endoresection. I think that radiation often works really well. If you have a really, really large tumor that's too big for plaque brachytherapy, then often I will go to enucleation in those settings. I know that primary endoresection is used in a lot of places in the world, and with small gauge vitrectomy, they've had some pretty decent results. But personally, I don't do it. I'm a little bit uncomfortable with the risk of extraocular extension, etc. I have used it post-radiation in some situations where the lesion is fairly large and there's concern about tumor lipid exudation syndrome or the effects of the amount of radiation and how it's going to affect the rest of the retina. And so in those scenarios, post-radiation treatment, I do occasionally do it using silicone oil afterwards.
Thank you, Dr. Basso. That's great.
David,
tips. Again, see.
I think that we should be closing this session. Doctors, for sure, they are tired. I really want to say that we have had more than 1,000 colleagues registered. This is a new record. So Latin America, it's very happy with all of you. All the Ophthalmo University team, it's so proud to have you. And I don't have words for you guys. Thank you so much for this incredible webinar. We really hope to repeat as soon as possible. Thank you so much. David, please, one word from all of you to finish this incredible session.
Thank you, Dr. Andres. It was such a pleasure to have all my colleagues with me and my great mentor, Dr. Shields, being here in this panel. I think I say from all ocular oncologists that we are not that scary. You can come to us and ask questions. I know it's a scary disease, but it's something that we have changed over thanks to doctors like Dr. Shields and their hard work for so many years, that the ocular oncology is not what it used to be before. We're not enucleating all the eyes, and that is no longer the option for many patients. So we can provide great quality of life and amazing visual acuity with all the advances, the nomograms, the new techniques in biopsy, the new ultrasounds, the magnetic resonance. I think a lot is going our way. I think we must be the branch of ophthalmology that is growing more and more and advancing at a faster pace than anybody else. So, and this is all thanks to the people that have worked very hard in this area. So thanks again to my colleagues, to my mentor, and thank you again for accepting this invitation. I hope this is the first one of many, and it's great to see you. A big hug from myself, hoping all of you are staying safe, and thank you again for keep teaching me every day. Thank you.
Doctors, some words to finish this webinar, and for all Latin America, they are listening. We are listening.
Thank you so much for having us. I was really thankful to have this opportunity to be with all of my friends and to hopefully teach something to all of you. And I think especially in difficult times like this, really the whole world needs to stick together. So it's really wonderful to have opportunities to come together like this.
Well, congratulations. I think you elaborated a perfect program, a perfect webinar, and it's really important to spread about ocular oncology, the early detection of tumors, and well, to tell them we're not scary, you can talk to us. I like that really much. So thank you very much. As I said, I'm really honored to be here with you, and congratulations. Stay safe, all of you.
Yes, I agree completely. Thank you so much for the opportunity to speak. It was great seeing so many old friends and making some new friends here digitally on Zoom. Thank you for the opportunity to speak. It was a great time. Look forward to more things like this, for opportunities to learn from a distance and opportunities to share knowledge as well. Agree, everybody stay safe and stay healthy. Thank you.
Hansel. Before Dr.
Yo
Shields.
solamente quiero decir algo, y lo quiero decir en español porque hay muchas personas, muchos residentes que nos están viendo, y como David ya lo ha dicho anteriormente, no tengan miedo de comunicarse con cualquiera de nosotros. Estamos muy abiertos para ayudarlos en lo que necesiten y en lo que podamos. Y es verdad que todos estos temas son complejos, pero para algo es que nos apoyamos entre todos.
Gracias, Hansel. Thank you so much.
Dr. Shields, some words?
Yes, well, I'd like to congratulate you, David, on a wonderful symposium. It was so exciting that even my husband, Jerry, came to listen to it. He heard all those familiar voices. And I'd like to congratulate all the panelists, even Dr. Rubens Belfort Jr., coming and making an appearance with the panelists. Congratulations to Dr. Morales. I learned a lot about ultrasound. Your technique is beautiful. Dr. Williams, well, I already gave you a good morning this morning through email. And we had a lot of fun working with Dr. Williams when he was a fellow. Dr. Lauren, she's an excellent ocular oncologist, a very scientific mind, and she gave a wonderful talk. And you, David, you're like the matchmaker. You brought us all together, and I hope we can do this again. I really think this is a really well done webinar with high quality talks. Lots to learn. Thank you.
David, lo último, gracias por ser el ideólogo, for being the organizer of this incredible webinar. We can say from Ophthalmology University, 1000 thank you. Mil gracias de parte de todos los que estamos acá. See you soon, stay safe, and hope to see you soon.
Thank you, everybody. Bye-bye. Thank you. Thank you, Dr. Shields.
See you,
Thank
guys.
you, Lauren. Thank you, Basil. Thank you, Melina. Thank you, Rubens. Thank you, Hansel. Bye-bye.